Welcome to another deep dive. This time, we're going to be diving into the world of pediatric surgery.
Oh, very cool.
And what's fascinating is we're going to be using an Arabic text for this.
Wow.
It's called, well, even in Arabic, it's basically pediatric
Yeah.
surgery, but the Arabic title is Siche.
Very cool.
So it's interesting to see that, these medical texts are shared globally.
Yeah.
And whether you're, studying for an exam or you are a medical professional or just curious about pediatric surgery, this is kind of your shortcut to expertise.
Absolutely. Yeah. We're going to be breaking down some really complex topics, I think,
Sure.
and trying to make them clear and understandable for everyone.
Yeah. So let's start with the scenario. Imagine a worried parent brings their child to the clinic and the child has a noticeable lump in their neck.
Uh,
As a medical professional, where do you even begin to figure out what's going on?
Well, the source material really cleverly breaks it down by location first. So is it a midline mass, right in the middle? Or is it more lateral or posterior, meaning off to the side or more to the back of the neck?
Okay. So you're looking at the location of the mass.
Exactly, yeah. And then from there, there's a simple observation that can be really helpful. Does the mass move when the child swallows?
Okay. Interesting. So location and movement are the first clues.
Right.
Now, let's say we have a midline mass and it moves when the child swallows. The source material points to a thyroglossal duct cyst as a likely culprit. So what exactly is that?
So a thyroglossal duct cyst is a little pocket of fluid that forms from a remnant of fetal development. Imagine, like a tiny little tube that connected the developing thyroid gland to the tongue.
Okay.
And sometimes a part of this tube doesn't disappear like it should.
Interesting.
And that's where the cyst can form.
So it's like a little piece of the past still hanging around.
Exactly.
And that explains why it moves when the tongue moves, right?
Yeah.
That makes sense. Um, the source also mentions that the cyst trunk procedure, which is this surgical removal of this cyst, involves removing a part of the hyoid bone.
Yeah.
Why is that necessary?
So the hyoid bone is this U-shaped bone that kind of sits in your neck.
Mm-hmm.
And the thyroglossal duct, even though it's just this tiny remnant, it often passes right through it.
Okay.
So to completely get rid of the cyst and prevent it from coming back, surgeons have to take out a small part of the hyoid bone as well.
Wow, that's pretty delicate.
It is, yeah, it's a delicate procedure, but it just highlights the importance of careful diagnosis and meticulous surgical technique.
Yeah, absolutely. Okay. Now, shifting gears a bit, those masses that are off to the side of the neck,
Okay.
the source talks about branchial cleft cysts.
Right.
These sound kind of like, those evolutionary leftovers you were talking about.
Yeah, you're exactly right. Branchial cleft cysts are the remnants of these structures called branchial clefts, which are involved in the formation of the head and neck during early development. And usually they disappear, but sometimes little pieces remain and then can form cysts later in life.
Fascinating. It's like a little reminder of our evolutionary history tucked away in our bodies. The source also notes that sometimes fluid analysis from these cysts, they can reveal cholesterol crystals.
Yeah.
What's the significance of that?
It's interesting because finding those cholesterol crystals isn't just like a random thing. It's actually a reminder that these cysts are lined with cells that are similar to the cells found in other parts of the body that, handle cholesterol.
Okay.
So it links back to basic biology and how our cells function. Even seemingly unrelated parts of our body share common characteristics.
Okay, so we've got thyroglossal duct cysts in the midline,
Right.
branchial cleft cysts off to the side.
Yep.
The source also describes cystic hygromas,
Yes.
and these sound a bit more complex.
They are a bit different. So cystic hygromas are malformations of the lymphatic system, which is like this network of vessels that helps drain fluid and fight infection. And these malformations can result in these fluid-filled sacs that can actually grow quite large.
The source also mentions a diagnostic tool called transillumination.
Oh, yeah.
What does that even mean?
Transillumination is really cool, actually. It's very simple. It just means shining a light through the mass.
Okay.
And because cystic hygromas are filled with fluid, that light shines right through.
Oh, wow.
It almost makes the mass glow.
So shining a light can literally illuminate the diagnosis.
Yeah, it's pretty amazing.
Now, before we move on from neck masses, I have to ask, are there any insights or tips that surgeons keep in mind when they're dealing with these cases? Something that our listeners might find interesting?
Yeah, there's one that always stands out to me, and it's that surgeons are super careful when they're removing masses that are on the back of the tongue.
Okay.
And the reason for that is because of the way that the thyroid gland develops. Sometimes the only functional thyroid tissue that someone has can actually end up there.
Oh,
So
wow.
you could accidentally remove someone's only source of thyroid hormone.
That definitely highlights the need for, a very thorough diagnosis and
Absolutely.
precise surgery.
Yeah. And just to add one more layer, it's important to remember that cystic hygromas can also be associated with Turner syndrome, which is a genetic condition.
Hmm.
So it just underscores how all the different systems in the body are interconnected
Yeah.
and how a seemingly isolated finding in the neck can actually be a clue to something much bigger.
Okay. So we've delved into the world of neck masses. Let's shift gears and head south, so to speak, to the chest. The source material dives into congenital anomalies of the thorax, and it
Mhm.
starts with tracheoesophageal fistula, or TIF.
Okay.
Can you give us a picture of what TIF is all about?
So imagine like the baby's esophagus, which is the tube that carries food from the mouth to the stomach,
Right.
and then you have the trachea, which is the windpipe that carries air to the lungs.
Yeah.
In teeth, there's this abnormal connection, like a little detour, between these two tubes.
Okay.
It shouldn't be there at all.
So it's like a mix-up in the plumbing of the respiratory and digestive systems.
Yeah, exactly.
What happens when a baby with teeth tries to eat?
So that's where things get challenging, because when the baby swallows, the milk or formula can go down the wrong pipe and end up in the trachea,
Oh, wow.
which leads to choking and coughing and difficulty breathing.
That sounds incredibly distressing.
It is. It's really tough for the baby and obviously really scary for the parents.
So how do doctors diagnose TEF?
Often, it's actually picked up right at birth when the doctors try to pass a small feeding tube down the baby's esophagus.
Okay.
And if they meet resistance or the tube kind of coils up, it's a red flag.
Mm-hmm.
And then an X-ray can confirm the diagnosis by showing the misplaced tube.
So it's a combination of clinical observation and imaging.
Right.
Now, how do you treat this condition?
So the definitive treatment for T is surgery.
Okay.
Surgeons carefully close off that abnormal connection and then reconnect the esophagus and the trachea the way they're supposed to be. It's a delicate procedure, especially in newborns,
Yeah.
but it can make a huge difference in the baby's ability to breathe and eat properly.
Okay. Well, that's reassuring. Now, moving on to another congenital anomaly of the thorax. The source describes congenital diaphragmatic hernia, or CDH. What makes this condition so serious?
So CDH involves a hole in the diaphragm,
Okay.
which is the muscle that separates the chest from the abdomen.
Right.
And because of this hole, abdominal organs like the intestines and the liver
Mm-hmm.
can actually move up into the chest cavity,
Oh, wow.
and they end up crowding the developing lungs.
So it's like a space issue in the chest.
Yeah, exactly. The organs are competing for space, and unfortunately, the lungs lose out.
What are the consequences of this crowding?
Well, the major one is something called pulmonary hypoplasia, which means the lungs just don't develop properly.
Okay.
And this can lead to serious breathing problems for the baby,
Right.
both immediately after birth and potentially throughout their life.
Now, the source mentions two main types of CDH, Bactelec and Morgagni.
Right.
Is there a key difference between the two types that we should be aware of?
Yeah, so the main difference is in the location of the hole in the diaphragm.
Okay.
Bactelec hernias, which are more common, they happen at the back and side of the diaphragm, while Morgagni hernias are more towards the front.
Okay.
And this difference in location can actually influence, the severity of the condition and how the surgery is approached.
So location matters even within the chest cavity. Now, imagine a newborn that's suspected of having CDH. What would be some of the telltale signs?
So the most striking sign would be severe respiratory distress,
Okay.
meaning the baby's really struggling to breathe. You might also see a sunken abdomen
Okay.
because those organs have moved up into the chest.
Mm-hmm.
And if you listen with a stethoscope, you might even hear bowel sounds in the chest, which is definitely not where they should be.
Wow. Okay, so are there any specific findings on a chest X-ray that confirm the diagnosis?
Oh, yeah, absolutely. An X-ray would clearly show gall gas in the chest cavity, which is a definite sign that those abdominal contents have moved up. And the mediastinum, which is the central part of the chest where the heart sits, it might be shifted to the side because of the pressure from the herniated organs.
Okay, so the X-ray provides visual confirmation of what's happening inside the chest. What's the prognosis for babies born with CDH?
Unfortunately, the prognosis really depends on how severely the lungs are underdeveloped.
Mm.
The more crowded they are, the harder it is for the baby to breathe. And sadly, even with advanced medical care, the survival rate for babies with CDH is only about 50%.
Wow, that's sobering to hear. It highlights the critical role of early diagnosis and intervention in these cases. Now let's shift our attention from the chest to the abdominal wall. The source discusses three key defects: gastroschisis, omphalocele, and inguinal hernias. Can you start by outlining the key differences between gastroschisis and omphalocele?
Sure. So both gastroschisis and onfolco involve the abdominal contents kind of being found outside the body. But the key difference is whether or not there's a protective covering. So in gastroschisis, there's a hole in the abdominal wall, typically next to the belly button. And the intestines protrude through this hole, but there's no membrane covering them.
So the intestines are just like exposed to the environment.
Exactly. And that's why infection is a major concern with gastroschisis.
Yeah, I can imagine.
Those delicate intestines are vulnerable to bacteria and other things. The good news is that gastroschisis is often detected on prenatal ultrasounds.
Okay.
So doctors can plan for deliveries and be ready to intervene surgically right away.
That's crucial then for minimizing the risk of complications. What does surgical intervention for gastroschisis involve?
Surgeons carefully place those exposed intestines back into the abdominal cavity and close the defect in the abdominal wall. Sometimes this can be done in a single surgery,
Okay.
but sometimes if the intestines are really swollen or there's not enough room in the abdomen, they might do it in stages.
Okay. So now let's compare that to omphalocele.
Okay.
What's the key distinction there?
So in omphalocele, the abdominal contents, and this can include intestines, liver, and other organs, they protrude through a defect at the base of the umbilical cord.
Okay.
But the key difference here is that they are covered by a protective membrane
Okay.
made up of the peritoneum and amnion, which are the tissues that surround the baby in the womb.
So it's like the abdominal contents are herniating into a sac outside the body, but they're still protected.
Exactly. That membrane helps reduce the risk of infection
Okay.
and drying out of the organs. However, omphalocele is often associated with other genetic syndromes.
Interesting.
So a thorough evaluation is really important to rule out any other potential problems.
So while both gastroschisis and omphalocele involve organs outside the body, the presence or absence of this protective membrane is like a key distinguishing feature.
Exactly.
Now, let's move on to inguinal hernias, which the source describes as a common pediatric surgical condition.
Yeah.
So what makes them so common?
So inguinal hernias in babies, specifically indirect inguinal hernias, they're common because of this persistent connection called the processus vaginalis.
Okay.
And this connection is a leftover from fetal development.
Okay.
It's basically like a little tunnel that allows the testicles to descend from the abdomen into the scrotum.
Oh, interesting. So it's another one of those remnants of development that can cause problems later on. What happens when this connection persists?
It creates a weak spot in the abdominal wall. And that weak spot allows the abdominal contents, usually a loop of intestine, to protrude into the inguinal canal,
Okay.
which is the passageway that leads to the scrotum.
The source also mentions that premature babies and males are more prone to inguinal hernias.
Yes.
Is there a reason for that difference?
Premature babies are more susceptible because they just haven't had as much time for that processus vaginalis to close naturally.
Mm-hmm.
And in males, the right testicle often descends a little later than the left, which can increase the risk of a hernia on that side.
So it's like a combination of developmental timing and anatomical differences between the sexes.
Yeah.
Now, let's say a parent notices a bulge in their baby's groin area.
Okay.
What are some key signs that would suggest an inguinal hernia?
So the bulge might be more prominent when the baby cries or strains,
Okay.
and then disappear when the baby's relaxed.
Mm-hmm.
The key is to seek medical attention promptly. Some hernias can be gently pushed back in, but it's important for a doctor to evaluate it because there's always a risk of the bowel getting trapped or strangulated.
Trapped or strangulated? That sounds pretty serious. What exactly does that mean?
So incarceration means the bowel is stuck in the hernia and it can't be reduced or pushed back in.
Okay.
This can cause pain, vomiting, even bowel obstruction.
Mm-hmm.
Strangulation is even more serious because that means the blood supply to that trapped bowel is cut off.
Oh, wow.
And that can lead to tissue death, which requires emergency surgery.
So it's definitely not something to wait and see about.
Yeah.
Now, before we move on to gastrointestinal defects, are there any other common conditions that parents might confuse with inguinal hernias?
Yes, so it's important to differentiate inguinal hernias from hydroceles.
Okay.
So a hydroceles is a fluid-filled sac that also causes swelling in the scrotum, but it's usually painless
Okay.
and often resolves on its own.
So how can you tell the difference?
A doctor can easily tell the difference during a physical exam.
Okay, that's good to know so parents don't needlessly worry if they see any scrotal swelling.
Exactly.
Yeah.
Always best to err on the side of caution and check with your pediatrician.
All right, now let's delve into the world of gastrointestinal defects,
Okay.
which can cause a wide range of problems for babies, from feeding difficulties to, life-threatening complications. The source starts with pyloric stenosis.
All right.
What's the underlying problem in this condition?
So pyloric stenosis is all about a bottleneck at the exit of the stomach. The pylorus, which is this muscular valve that controls the flow of food from the stomach into the small intestine, it gets abnormally thickened. And that creates this narrowing that obstructs food.
So it's like a traffic jam in the digestive system,
Exactly.
with food backing up in the stomach.
Yeah.
So what happens to babies with this condition?
So the classic sign of pyloric stenosis is projectile vomiting. This is where the baby forcefully expels milk or formula shortly after feeding.
Oh, wow.
Like it shoots across the room.
Okay. So are there any other clues that might point to pyloric stenosis?
Besides that projectile vomiting, babies with pyloric stenosis might be constantly hungry but failing to gain weight
Okay.
because they're not digesting their food. And during a physical exam, doctors can sometimes feel a small, firm mass in the baby's abdomen.
Mm-hmm.
It feels like a little olive.
Okay.
And that's the thickened pyloric muscle.
So the combination of those symptoms and the physical findings can raise suspicion.
Right.
How do doctors confirm the diagnosis?
So an ultrasound is really the gold standard for diagnosing pyloric stenosis.
Okay.
It can clearly show the thickened muscle and that narrowed passageway. Sometimes a barium swallow study might be done as well.
Okay.
That's where the baby swallows a liquid that contains barium, which shows up on x-rays.
Mm.
And it helps visualize the flow through the stomach and intestines.
Okay, so once the diagnosis is made, what's the treatment for pyloric stenosis?
The good news is that it's very treatable
Okay.
with a surgical procedure called a pyloromyotomy.
Mm-hmm.
So in this procedure, the surgeon makes a small incision in that thickened pyloric muscle, which relieves the obstruction and allows food to pass through.
So it's like loosening the bottleneck to restore normal flow.
Exactly.
What's the typical recovery like after this procedure?
It's usually quite smooth. Most babies can start feeding again within a day or two,
Oh, wow.
and they quickly regain their lost weight. It's a very safe and effective procedure with excellent long-term outcomes.
Okay. Well, that's great. Now let's move on to another gastrointestinal condition that affects the flow of bile.
Okay.
This is called biliary atresia.
All right.
Can you explain what this condition entails?
So biliary atresia is a blockage of the bile ducts.
Okay.
These are tiny tubes that carry bile from the liver to the gallbladder and the small intestine.
Mm-hmm.
And bile is crucial for digesting fats. When it can't flow freely, it backs up in the liver, which causes damage and scarring.
So it's a problem with drainage, and that backup can have serious consequences for the liver. What are some of the signs and symptoms of biliary atresia?
The most obvious sign is persistent jaundice.
Okay.
So that's yellowing of the skin and whites of the eyes that doesn't fade away like typical newborn jaundice.
Right.
The baby's stools might also be pale or clay-colored because that bile isn't reaching the intestines
Oh,
to
interesting.
give them their normal brown color.
So the color of the baby's skin and stools can provide important clues. How do doctors diagnose biliary atresia?
It can be tricky because it often mimics other liver conditions.
Mm-hmm.
So doctors might start with an ultrasound just to visualize the liver and bile ducts.
Okay.
Then they might do a HIDI scan, which uses a radioactive tracer to track the flow of bile.
Okay.
And sometimes a liver biopsy is necessary to confirm the diagnosis
Mm-hmm.
and see how much damage there is.
So once the diagnosis is confirmed, what are the treatment options?
So the main treatment for biliary atresia is the Kasai procedure.
Okay.
It's named after the Japanese surgeon who developed it.
Mm-hmm.
And this procedure involves creating a new pathway for bile to drain from the liver into the intestine.
Okay.
It basically bypasses the black ducts.
So it's a surgical solution to reroute the flow of bile. What are the chances of success with the Kasai procedure?
It really depends on a few factors,
Okay.
including the age at diagnosis and how much liver damage there is. If it's done early, it can significantly improve bile flow and liver function. But even with a successful Kasai procedure, many children with biliary atresia will eventually need a liver transplant.
That highlights the seriousness of this condition
Yeah,
and the need for, ongoing monitoring and management.
absolutely.
Now, let's turn our attention to a condition that involves twisting of the intestines. Malrotation and midgut volvulus.
Okay.
Can you explain the difference between those two terms?
Sure. So malrotation basically refers to an abnormal rotation of the intestines during fetal development.
Mm-hmm.
The intestines don't end up where they're supposed to be, which can lead to problems with digestion.
So it's like a mix-up in the arrangement.
Exactly.
Now, what's the connection between malrotation and midgut volvulus?
Midgut volvulus is a serious complication that can happen as a result of malrotation.
Okay.
Those twisted intestines can twist even further,
Mm-hmm.
and that can actually cut off the blood supply to a portion of the bowel.
Oh, wow.
This is a surgical emergency
Okay.
because you have to intervene right away to prevent tissue from dying.
Right. So it's like a kink in a hose that restricts the flow. What are some telltale signs that a baby might be experiencing midgut volvulus?
So the signs of midgut volvulus often come on suddenly and dramatically.
Okay.
The baby might start vomiting bile,
Mm-hmm.
which is that green or yellow fluid produced by the liver, and the abdomen might become distended and tender. You might also see blood in the baby's stool.
Okay. Those sound like alarming signs that would warrant immediate medical attention.
Absolutely.
So what diagnostic tests are done to confirm the diagnosis?
An abdominal x-ray is often the first step,
Mm.
and it can show signs of bowel obstruction and a characteristic finding called the double bubble sign.
Okay.
This is where gas is trapped in the stomach and the duodenum, indicating a blockage.
The double bubble sign. It sounds almost cartoonish,
I know, right?
but it's clearly a serious finding.
It is, yeah.
What's the treatment for midgut volvulus?
So emergency surgery is really the only way to address it. The surgeon untwists the bowel and, if necessary, removes any dead tissue. The goal is to restore blood flow to that area and prevent further complications.
So it's a race against time to save the affected bowel.
It is.
Now, let's move on to another type of blockage in the digestive system. Duodenal atresia.
Okay.
What is this condition, and how does it differ from midgut volvulus?
So duodenal atresia is a complete blockage of the duodenum,
Okay.
which is the first part of the small intestine.
Right.
Unlike midgut volvulus, which involves twisting, duodenal atresia is a congenital defect,
Okay.
meaning it didn't form properly during fetal development.
So it's a structural problem rather than a functional one.
Right.
What are the consequences of this blockage?
Well, because the duodenum is completely blocked, food can't pass from the stomach into the intestines.
Okay.
And this can lead to bilious vomiting, abdominal distension, and failure to pass meconium, which is the first stool.
The source mentions that duodenal atresia is often associated with Down syndrome.
Yes,
Is there a known connection there?
there is. There's a higher incidence of duodenal atresia in babies with Down syndrome.
Okay.
And this just underscores the importance of a thorough evaluation for any baby born with Down syndrome
Yeah.
to make sure there aren't any GI problems.
So early detection and intervention are key in these cases. How do doctors diagnose duodenal atresia?
Similar to midgut volvulus, an abdominal x-ray can reveal signs of bowel obstruction and that characteristic double bubble sign.
Mm-hmm.
However, in duodenal atresia, the double bubble is usually more prominent and located higher up in the abdomen.
So while the double bubble is a common finding in both conditions, the location and severity can help distinguish between them.
Exactly.
What's the treatment for duodenal atresia?
Surgery is the only definitive treatment.
Okay.
The surgeon will create a bypass around that blocked portion of the duodenum, allowing food to pass from the stomach into the intestines.
Okay. So we've covered a range of conditions that involve blockages in the digestive tract. Now let's turn our attention to intussusception. The source describes this as a condition where the intestine telescopes into itself.
Yes.
Can you elaborate on what that means?
So intussusception is where one segment of the intestine slides into the adjacent segment, kind of like those old collapsible telescopes.
Oh, wow. I can picture that.
Yeah.
What causes this telescoping to occur?
In most cases, the exact cause is unknown, but sometimes it can be triggered by an enlarged lymph node, a polyp,
What?
or even a Meckel's diverticulum, which we'll talk about later.
So it's like a chain reaction, with one abnormality leading to another. What are some of the classic signs and symptoms of intussusception?
Babies with intussusception often have this sudden severe abdominal pain that comes and goes in waves.
Okay.
They might cry inconsolably, draw their knees up to their chest, and vomit.
Mm-hmm.
And another hallmark sign is what we call current jelly stools, which contain blood and mucus.
Current jelly stools. That's a very descriptive term.
It is, yeah.
So what diagnostic tests are done to confirm intussusception?
An ultrasound is usually the first line test,
Mm-hmm.
and it can clearly show those telescope bowel segments.
Mm-hmm.
Sometimes a barium enema is performed, where contrast material is introduced into the rectum, and the pressure from the barium can actually sometimes push those telescope segments back into place, which effectively treats the intussusception.
Oh, wow. So the diagnostic procedure can double as a treatment.
Exactly, yeah. Sometimes it works out that way.
What happens if the barium enema doesn't work, or if there are concerns about damage to the bowel?
In those situations, surgery is necessary. The surgeon will manually reduce the intussusception and make sure the bowel is okay.
Okay.
Prompt intervention is crucial.
All right, so we've covered a range of conditions that affect the small and large intestines.
Right.
Now let's move on to a condition that affects the anal opening, imperforate anus.
Okay.
What does this condition entail?
So imperforate anus is a congenital defect where the anal opening is either absent or malformed.
Okay.
It's a rare condition, but it's important to always check for meconium passage in newborns, because a delay in passing that first stool can be a sign of a problem.
So it's a condition that can be detected early on
Exactly.
through careful observation.
Yeah.
The source mentions that imperforate anus can be associated with other congenital anomalies, summarized by the acronym VACTHERL.
Right.
Can you decode that acronym for?
VACTERL stands for vertebral defects, anorectal malformations, cardiac defects, tracheoesophageal fistula, renal anomalies, and limb abnormalities.
Okay.
So it's a reminder that sometimes these congenital defects can occur together,
Yeah.
which is why it's important to do a thorough evaluation for any newborn that has any suspected anomaly.
So it's like a checklist of potential problems to consider. What are the treatment options for imperforate anus?
It really depends on the severity of the defect.
Okay.
So for low lesions where the rectum ends just below the skin, a simple surgical procedure called an anaplasty can create a new anal opening.
Okay.
But for higher lesions where the rectum ends higher up, a colostomy might be necessary.
A colostomy, what does that involve?
A colostomy is a procedure where the colon is brought to the surface of the abdomen
Okay.
and an opening is created called a stoma.
Mm-hmm.
And stool will then exit the body through the stoma into a bag that's attached to the abdomen.
So it's a way to divert the flow of stool until a more definitive repair can be done?
Exactly. Yeah, it can be temporary. It allows the baby to grow and develop before they undergo further surgery to repair the imperforate anus.
Okay. So we've covered imperforate anus and the various approaches to treatment. Now let's circle back to a condition you mentioned earlier,
Okay.
Meckel's diverticulum.
Right.
What is a diverticulum and what makes Meckel's diverticulum unique?
So a diverticulum is basically an outpouching, like a little pocket, that forms in the wall of an organ.
Okay.
Meckel's diverticulum is a specific type of diverticulum that occurs in the small intestine.
Mm-hmm.
It's a remnant of this structure called the vitelline duct,
Okay.
which connected the yolk sac to the developing embryo.
Oh, interesting. So it's another one of those remnants of fetal development. That can sometimes cause problems.
Right. The source actually describes Meckel's diverticulum using the rule of twos.
The rule of twos. Okay. Can you break that down for us?
Yeah, so the rule of twos is just a way to remember some key features. It occurs in about 2% of the population.
Okay.
It's usually located about 2 feet from the ileocecal valve, which is where the small intestine joins the large intestine.
Mm.
It's about 2 inches long, and about 2% of cases are actually symptomatic.
That's pretty clever. So most people with Meckel's diverticulum never even know they have it.
Exactly. Most cases are asymptomatic and don't cause any problems.
Okay.
But for those who do have symptoms, it can be serious.
So what are some of the potential complications of Meckel's diverticulum?
So the most common symptom is painless rectal bleeding, which can be quite alarming.
Okay.
The diverticulum itself can get inflamed or infected,
Mm-hmm.
which can mimic appendicitis. And sometimes it can lead to bowel obstruction or intussusception, which we talked about earlier.
So while it's often a silent passenger, it can sometimes cause significant problems. How is it diagnosed?
Diagnosing Meckel's diverticulum can be tricky because the symptoms can mimic other things.
Yeah.
Sometimes it's found incidentally during surgery for something else.
Okay.
But there's a specialized test called a Meckel's scan that uses a radioactive tracer to detect the diverticulum.
Okay.
And that can be helpful in diagnosing those symptomatic cases.
And what's the treatment for Meckel's diverticulum if it is causing problems?
If it's causing symptoms or complications, surgical removal is usually recommended.
Okay.
And the surgery itself is pretty straightforward. They just resect the diverticulum and a small portion of the surrounding intestine.
Okay. So we've covered Meckel's diverticulum and the potential problems it can cause. Now let's move on to Hirschsprung's disease,
Go ahead.
which the source describes as a condition that affects the nerves of the colon.
Right.
Can you explain what's going on in this condition?
Sure. So Hirschsprung's disease is a congenital disorder that affects the large intestine, specifically the colon.
Mm-hmm.
And the problem is the absence of these nerve cells, called ganglion cells, in a segment of the colon,
Okay.
usually the rectum and the sigmoid colon, which is the part closest to the rectum.
So it's a problem with the wiring of the colon, so to speak.
Yeah, exactly.
What are the consequences of missing these nerve cells?
So those ganglion cells, they're responsible for coordinating the muscle contractions that move stool through the colon.
Okay.
And without those nerve cells, the affected segment can't contract properly, so it leads to a functional obstruction.
So it's like a traffic jam in the colon
Exactly.
with stool backing up because the muscles can't move it along.
Right.
What are the signs and symptoms of Hirschsprung's disease?
So in newborns, the classic sign is failure to pass meconium within the first 48 hours of life.
Okay.
That's a big red flag.
Mm.
Older children with Hirschsprung's disease might have chronic constipation, abdominal distension, and vomiting.
Okay. So the symptoms can vary depending on the age of the child.
Right.
How is Hirschsprung's disease diagnosed?
A barium enema can show the characteristic narrowed segment of colon.
Okay.
That's affected by the lack of ganglion cells. The definitive diagnosis is made by a biopsy of the colon, which confirms the absence of those nerve cells.
And once the diagnosis is made, what's the treatment for Hirschsprung's disease?
Surgery is the only definitive treatment.
Okay.
The surgeon removes the affected segment of colon and reconnects the healthy portions.
Mm-hmm.
Sometimes a temporary colostomy might be necessary, especially in newborns,
Okay.
just to allow the bowel to rest and heal before that definitive repair.
So it's a surgical solution to bypass the obstructed portion of the colon?
Right.
Now, let's turn our attention to a condition that primarily affects premature infants.
Okay.
This is necrotizing enterocolitis, or NEC.
Right.
What makes this condition so devastating?
So NEC is a very serious condition that affects the intestines of premature babies. And it can range in severity from mild to life-threatening.
Mm-hmm.
In NEC, portions of the intestine become inflamed and start to die
Okay.
due to a lack of blood flow and bacterial invasion.
So it's a combination of factors
It is.
that compromise the health of the intestines. What are the signs and symptoms of NEC?
Babies with NEC might have feeding intolerance, abdominal distension, vomiting, and bloody stools. They might also have systemic signs like fever or hypothermia, lethargy, and difficulty breathing.
Those sound like very general symptoms
There you are.
that could indicate a variety of problems.
Right.
How do doctors diagnose NEC?
An abdominal x-ray is crucial.
Okay.
It can show signs of intestinal dilation, gas in the bowel wall, which we call pneumatosis intestinalis,
Mhm.
and even air in the portal vein, which carries blood from the intestines to the liver.
Okay.
And those findings all indicate severe bowel damage.
So the X-ray provides visual evidence of the extent of the problem.
Exactly.
What's the treatment for NEC?
It depends on the severity.
Okay.
Mild cases might resolve with supportive care, like bowel rest, antibiotics, IV fluids.
Mhm.
But severe cases might require surgery to remove the dead portions of the intestine.
So it's a multi-pronged approach
Yep.
that aims to control the infection, support the baby's overall health, and address any surgical emergencies.
Exactly.
Now, let's move on to meconium ileus,
Okay.
which the source describes as a bowel obstruction caused by thick, sticky meconium.
Right.
Can you explain what makes meconium ileus unique?
So meconium ileus is a type of bowel obstruction that occurs when the meconium, that first stool the baby passes, is abnormally thick and sticky,
Okay.
and it prevents it from passing through the intestines. It's strongly associated with cystic fibrosis,
Okay.
which is a genetic disorder that affects the production of mucus, sweat, and digestive fluids.
So it's a bowel obstruction with a specific cause linked to a genetic condition.
Right.
What are the typical signs and symptoms of meconium ileus?
Babies with meconium ileus will fail to pass meconium within the first 24 hours of life.
Okay.
They might also have abdominal distension, vomiting, and failure to thrive.
How is meconium ileus diagnosed?
An abdominal x-ray is usually the first step.
Okay.
It can show signs of bowel obstruction, dilated loops of intestine, and sometimes even air fluid levels.
Mm.
A contrast enema, where contrast material is introduced into the rectum, can help confirm the diagnosis.
Okay.
And sometimes it could even dislodge the impacted meconium.
So, similar to intussusception, the diagnostic procedure can sometimes double as a treatment.
Yeah, exactly.
What's the treatment for meconium ileus if the contrast enema isn't successful?
If it doesn't work, or if there are complications, surgery is necessary to remove the impacted meconium and address any other problems,
Okay.
like intestinal atresia, which is a narrowing or complete blockage of the intestine.
Okay. So we've covered a wide range of gastrointestinal defects, each with its own unique challenges
We have.
and treatment approaches.
Mhm.
Now let's shift gears and move on to urogenital defects,
Huh?
which the source highlights as important considerations in pediatric surgery.
Right.
The first condition discussed is urethral abnormalities.
Right.
Can you explain what the urachus is and what kind of problems can arise?
So the urachus is this tubular structure that connects the fetal bladder to the umbilicus, or belly button, during development.
Okay.
And it usually closes off before birth,
Mm-hmm.
but sometimes remnants can persist and cause problems.
So it's like a leftover pathway between the bladder and the belly button.
Exactly.
What kind of problems can these remnants cause?
One common issue is a urachal cyst,
Okay.
which is a fluid-filled sac that forms along the urachus.
Mm-hmm.
These cysts can get infected, causing pain, swelling, and redness around the belly button.
That doesn't sound fun. Are there any other potential complications?
Yeah, sometimes the urachus can stay partially open,
Okay.
creating a connection between the bladder and the umbilicus,
Mm-hmm.
and this can lead to urine leaking from the belly button.
Oh, wow. So it's not just a matter of discomfort. It can also affect hygiene and daily life.
Right.
How are urethral abnormalities diagnosed?
So doctors might suspect it based on the symptoms,
Mm.
like discharge or a mass around the belly button.
Okay.
Imaging tests like ultrasound or a sonogram can help confirm the diagnosis.
So imaging can provide a clear picture of what's going on.
Yeah.
What's the treatment for urethral abnormalities?
If it's causing symptoms, surgical removal is usually recommended just to prevent complications.
Oh, that makes sense. Now, moving on to another urogenital defect,
Okay.
the source discusses undescended testicles.
Right.
Can you explain what that means and why it's a concern?
Sure. So undescended testicles, also known as cryptorchidism, is a condition where one or both testicles fail to descend from the abdomen into the scrotum
Okay.
during fetal development.
So instead of ending up in their normal location,
Right.
the testicles are stuck somewhere along the way.
Exactly.
Why is that a problem?
So the scrotum provides a cooler environment than the abdomen, which is important for normal sperm production.
Okay.
Undescended testicles have a higher risk of infertility, as well as other complications like testicular torsion and cancer.
So it's not just about fertility. There are other potential health risks as well.
Right.
How common is undescended testicles and how is it diagnosed?
It's relatively common, affecting about 3–4% of full-term baby boys.
Okay.
And it's usually diagnosed during a physical exam.
Mm-hmm.
The doctor just checks for the presence of testicles in the scrotum.
So it's a condition that can be detected early on through a simple physical exam.
Yes.
What are the treatment options for undescended testicles?
In many cases, the testicle will descend on its own within the first few months of life.
Okay.
But if it doesn't descend by 6 months of age, surgical treatment called orchiopexy is usually recommended.
Can you describe what orchiopexy involves?
Sure. During orchiopexy, the surgeon makes a small incision in the groin, carefully brings the testicle down into the scrotum, and secures it in place.
So it's a surgical solution to relocate the testicle to its proper place?
Exactly.
What are the long-term benefits of addressing undescended testicles?
It improves the chances of fertility,
Mhm.
and it reduces the risk of testicular torsion and cancer.
Okay, so we've covered a wide range of pediatric surgical conditions from head to toe, so to speak.
We have.
Now, let's step back and reflect on some of the key takeaways from this deep dive.
Okay.
What are some overarching themes or insights that stand out to you?
One of the most striking things to me is the incredible complexity of fetal development.
Yeah.
Even tiny disruptions in this intricate process can have significant consequences later on.
That's a great point. We've seen how remnants of fetal structures like the thyroglossal duct and the urachus can cause problems.
Right.
And we've explored how developmental errors, such as malrotation of the intestines, can lead to serious complications.
Yeah.
Another key takeaway is the importance of early diagnosis and intervention in pediatric surgery.
Oh, for sure.
Yeah.
Many of the conditions we've talked about can be effectively treated if they're caught early.
Absolutely. Early intervention can minimize the risk of complications, improve long-term outcomes, and even save lives.
Couldn't agree more. And I think it's also worth highlighting the incredible advances in surgical techniques
Yeah.
and technology that have made these interventions safer and more effective than ever before.
Yes, that's a point that often gets overlooked. Pediatric surgeons are incredibly skilled
Oh, they are.
and dedicated individuals who are constantly pushing the boundaries of what's possible.
They're masters of their craft.
Yeah.
Now, shifting gears a bit, what impressed you the most from this Arabic medical text?
I think what struck me most was the clarity and detail with which it explained these complex conditions. It was like a guided tour through the intricacies of pediatric surgery,
Yeah.
highlighting not only the anatomical and physiological aspects,
Right.
but also the diagnostic and therapeutic approaches.
I agree. It provided a really comprehensive overview of the essentials
Yeah.
and made it accessible, I think, to a wide audience.
Absolutely. It really emphasized the power of clear communication in
Mhm.
conveying complex medical information. It also reminded me of how crucial it is to have access to reliable and accurate medical resources,
Absolutely.
regardless of language or geographical location.
That's a powerful point.
Yeah.
Medical knowledge should be accessible to everyone.
Yeah,
And this text exemplifies that, the sharing of knowledge.
absolutely. Now let's do a quick recap of some of the key conditions we've covered.
Okay.
We started with neck masses,
Right.
exploring the differences between thyroglossal duct cysts, branchial cleft cysts, and cystic hygromas,
Mhm.
highlighting the importance of location and movement in guiding the diagnosis.
Right. And how those subtle clues can lead to the right treatment.
Yeah. Then we moved down to the chest, delving into the complexities of tracheoesophageal fistula, or TAF, and congenital diaphragmatic hernia, or CDH.
Yes.
These conditions highlighted the critical importance of early recognition and intervention in neonatal care.
Absolutely. Those are conditions that can be life-threatening, but with prompt diagnosis and treatment, outcomes can be so much better.
From the chest, we shifted our focus to the abdominal wall, discussing the differences between gastroschisis and omphalocele,
Right.
emphasizing the presence or absence of a protective membrane as a key distinguishing feature.
And the challenges of managing those conditions, of course.
Yeah.
Yeah.
We also talked about inguinal hernias,
Mhm.
highlighting the importance of distinguishing them from hydroceles and addressing the potential risks of incarceration and strangulation.
And putting parents' minds at ease, hopefully.
Right. Then we ventured into the world of gastrointestinal defects, covering a range of conditions from pyloric stenosis to meconium ileus.
Mhm.
We discussed the various causes of intestinal obstruction,
Right.
the diagnostic tools used to identify these problems, and the surgical techniques employed to correct them.
It was a lot of information, but we got through it.
We did. And I think we highlighted the importance of a multidisciplinary approach,
Absolutely.
involving pediatricians, surgeons, radiologists, and other specialists.
Teamwork makes the dream work.
Yes, it takes a team to provide the best possible care for these young patients. And finally, we wrapped up with urogenital defects,
Right.
focusing on urachil abnormalities and undescended testicles. These conditions illustrate the importance of understanding the developmental origins of these problems and the potential long-term consequences of leaving them untreated.
Absolutely. Seemingly minor things can have big impact.
Okay, so we've covered a lot of ground in this deep dive,
We have.
but I hope it's been valuable.
I think we provided a good overview.
I think so too. Now, before we wrap up, I want to leave our listeners with a thought-provoking question.
Oh, I like where this is going. What do you have in mind?
So, throughout this deep dive, we've encountered several conditions where seemingly unrelated body systems are interconnected. For instance, the link between cystic hygromas and Turner syndrome,
Right,
or
right.
duodenal atresia and Down syndrome.
It shows how interconnected everything is.
Exactly. So, my question for our listeners is this. Given these unexpected links, what other surprising connections might exist within the human body that we haven't yet discovered?
That's a great question. It really opens up a whole world of possibilities.
Absolutely. So keep exploring, keep asking questions, and keep marveling at the wonders of the human body.
Yeah, it's amazing how much we're still learning about the human body,
I know it's true.
especially in pediatric surgery.
Yeah, and this deep dive has really shown us that it's important to keep an open mind
Absolutely.
and be ready for new discoveries.
Yeah.
Who knows what we'll find out in the future.
It's an exciting time to be in medicine, for sure.
It is.
Now, as we wrap up this deep dive,
Hmm.
I want to say again that we didn't try to cover every little detail of pediatric surgery.
Right, no, this was not meant to be like a comprehensive textbook.
Yeah, instead we wanted to give you a good foundation
Like a starting point.
to understand these conditions and recognize them.
Yeah, so you can appreciate how important early diagnosis and treatment are.
We've just touched on the essentials,
Right, it's just the tip of the iceberg.
but there's so much more to learn.
Yeah, so if any of these conditions pique your interest,
Absolutely.
we encourage you to dig a little deeper.
Yeah.
You know, there's a lot of great resources out there.
For sure.
We mentioned some earlier, and, there are reliable websites and medical textbooks.
Right, those are great places to start.
And, of course, don't hesitate to talk to your doctor or healthcare provider if you have any questions.
Yes, they're your best resource for personalized advice.
So as we conclude this deep dive,
Mm.
we hope you've gained a better understanding of the complexities of pediatric surgery.
Yeah, it's challenging but rewarding work.
And the amazing work that these medical professionals do for these kids.
They really are making a difference.
We've only just scratched the surface of this field. But we hope we've made you a little bit more curious
Absolutely.
and empowered you to keep learning about the human body.
It's a fascinating journey.
It is until next time. Keep diving deep.